Good afternoon. My name is Joe Gottschalk. I'm a USF Internal Medicine PGY2. Today, we'd like to talk to you about velocity time integral as a hemodynamic assessment tool. This presentation is brought to you by a group of USF Internal Medicine PGY2s, including Bianca Glass, Nancy Nguyen, myself, Dalan Smallwood, and Bianca Sanchez. And today's date is September 12th, 2025. Next slide. So before we jump into velocity time integral or VTI, we'll take a step back and we'll talk a bit about POCUS, its applications to assess hemodynamics. So as you know, POCUS is becoming increasingly popular. It's a very effective way to augment your physical exams. You might get on your exams here some crackles, an x-ray, getting some conflicting knowledge here. So you do a POCUS and you can get some real-time data. Is this atelectasis? Is this pulmonary edema? So it all augments in real-time clinical decision-making. It's easy to use and it's fast. Taking this to the next step, POCUS to assess hemodynamics. So you can apply it to fluid management. You can assess are your vasopressors effective, guide shock management. Some of the more common hemodynamic measures that you might be a little bit more familiar with coming into this include left ventricular ejection fraction, RV size function is the right ventricle hyperdynamic, and then IVC collapsibility. For instance, if your IVC diameter is less than 2.1 centimeters with greater than 50% collapse when they're taking a sniff, suggests normal or low right atrial pressure. And then the IVC diameter is greater than 2.1 centimeters with less than 50% collapse, suggests elevated right atrial pressures. Next slide. So going into this, talking about what velocity time integral is, a working definition. So VTI is a dynamic and non-invasive method to measure distance that blood travels with one heartbeat. More or less functions as the stroke distance. We can use this and incorporate it to act as a surrogate for stroke volume. The application is most significant with serial measurements that are collected before or after an intervention, such as adding on vasopressors or fluid. And it can be calculated across various anatomic structures, but more commonly it's used as the LVOT or your left ventricular outflow tract. As you take a look to the right here, we use the principle that the left ventricular outflow is a cylinder. So you can use some simple math here and you can calculate the area of a circle here being your aortic outflow tract. And you can then use this to calculate your stroke volume here. So we'll talk about this a little bit more detail as you go into the next slide. So the VTI and cardiac output related and how you calculate these. So simply you can measure the left ventricular outflow diameter in centimeters. Then you can use the principle that the LVOT area can be calculated using the area of a circle. So when you do that, you can get your stroke volume is going to be your VTI times your LVOT area. In a second here, Dalan will talk about how to actually calculate the VTI. And then once you calculate the VTI, you can get your cardiac output, which is your heart rate times your stroke volume. But essentially, you get your stroke volume by using your VTI times your left ventricular outflow tract area. And again, this is a non-invasive measurement that's often useful in guiding fluid management and sepsis and trying to get some real-time calculations here. And Dalan's going to talk a little bit more in depth about how to actually get that VTI now.
And so the way that you measure your VTI is that you first want to use a phased array probe in the cardiac orientation to get a apical 5-chamber view. It's important that you need that LVOT in view, since that's where we're going to be making our measurement. And then you're going to use the pulse wave Doppler function on your ultrasound to measure to take your measurements. You're going to place your marker, as can be seen on the image noted there. You're going to place your marker slightly proximal to your aortic valve, and you want to try and get it so that it's perpendicular to the area of flow. So you're going to have that flow from your left ventricle to your aorta, and you want to make sure that those lines are kind of perpendicular to that so that you're getting an accurate measurement. And then you can create a waveform, and you see that waveform there on the right. And then you will use your tools to trace out that waveform, and then the machine will calculate an area under the curve where you have on your y-axis, looking at that graph there, the y-axis is going to be the velocity at a given point in time, and then the x-axis is going to be your actual time. And that waveform that we're seeing there is going to be 1 beat of your heart. And once it calculates that area under the curve, that will be what your velocity time integral is going to be. The normal range is going to be 18 to 22 centimeters. If it's less than 15 centimeters, that's suggestive of a low stroke volume. And if it's greater than 25 centimeters, it's going to be suggestive of a high stroke volume. Because our LVOT area is expected to be consistent, it's not going to change very much just due to the muscular structure of the arteries. This is a good surrogate marker for stroke volume. Next slide. Now, there are some pitfalls associated with VTI, one such being that it is user dependent, and that's the accuracy will depend on how well you can line up. As I said, you have to get that marker in the appropriate positioning near your aortic valve, but not distal to it. And then you have to make sure that it's lined up perpendicular to the direction of flow in order so that you can get a proper reading. And if you mess up that reading, it can give you a slightly, likely underestimate what your VTI is, and that can lead to some false understandings of what's going on with your patient. It's also dependent on patient positioning. Now, that's less of an issue, given that a lot of the patients that you're going to be measuring this in are going to be critically ill patients, and that you're trying to use this to guide fluid resuscitation. And those patients are often going to be ventilated, and so they're usually going to be in a consistent positioning, and you're usually going to be collecting these in a relatively short period of time. And so that's typically not going to be an issue, but it's just something to be aware of. It's important to also note that the most important part of this is the relative change versus the actual absolute measurement. We just talked about the normal low and high values for this, but what we're really focusing on is the relative change, and we'll talk a little bit more about why that's important, and that but you can have some false readings as well from other pathologies such as aortic stenosis and aortic regurg. They can give you falsely elevated readings of your stroke volume just because of the additional flow that is occurring, or the additional pressure gradient as a result of your aortic stenosis and aortic regurg that you need to be aware of. So it's important to implement this in the appropriate clinical context and aware of kind of what's going on with the patient. And finally, it can vary significantly with arrhythmias. There can be a lot of beat-to-beat variability between your stroke volume in arrhythmias. And so if you're doing this in, let's say, a patient with AFib with RVR, you want to average this across multiple beats in order to get a more accurate result of what's going on. Next slide. And so now we get to kind of the most important part of this presentation, which is what we're actually using this for, and it's important for assessing fluid responsiveness. There's a couple different methods that you use. The most common, or at the very least the most standard method, is going to be giving them a fluid challenge of usually about 500 cc's is the minimum you want to use, up to a liter, though 500, since you're trying to assess whether these patients are fluid overloaded versus hypovolemic, it's usually don't want to be giving them too much fluid, and so 500 cc's is a good cutoff for that. And you're trying to see if there's an increase of about 15% in your VTI between your initial measurement and after that fluid bolus. Now, there are some other methods that you can use that can give you that reduce the risk of potentially causing an already fluid overloaded patient to become more fluid overloaded while you're doing this. And that's the passive leg raise, where you lift the patient's legs in order to basically simulate a fluid bolus from the increased venous return from from the veins in your lower extremity, and that can give you that kind of comes out to that 500 cc's. So it gives you similar readings. There's also the mini fluid challenge test, where you use a smaller volume of fluid, only 100 cc's, and that has, in some studies, has been shown to have a sensitivity of 91.5% and a specificity of about 89% in patients if you use a cutoff of around 10% as opposed to that full 15%. Of course, we're not going to see quite that full measure given that these patients aren't receiving quite as much fluid. And then there's also the end expiratory occlusion test, which is specifically for patients that are intubated, where you have them take a breath, exhale, and then you hold the ventilator at the moment at the end of exhalation, basically, in order to simulate PEEP, or basically have the patient at their PEEP value. And then you kind of see if there is that similar fluid responsiveness, once again at a slightly lower in cutoff, around like 7%, I want to say was used in this study. And that also had a sensitivity and specificity of about 89% for both. And so these are just some methods that are less likely to cause potential harm to the patient that you can use as well to get an understanding of the VTI and whether or not this patient may benefit from fluids or more pressors exactly.
Yeah, so this is Bianca Sanchez. So just to kind of recap what we've gone over so far before we get into the actual application of everything, we've discussed what VTI is, how it's a measure of the amount of stroke volume or the amount of fluid being pumped out of the heart. We figured out how we're supposed to obtain that through our point of care ultrasound at the bedside. And Dalan did mention the kind of context we need to keep in mind when obtaining both our VTI measurement and also interpreting it in terms of, applying the clinical context. And then he did start to touch on the application of it in terms of fluid responsiveness and how we can use VTI to see if what we're doing is actually affecting the patient and how it's affecting the patient. So in terms of applying the VTI in the state of shock, we have, let's say, a context of our patient is stable-ish on pressors. We have our patient in multiple pressors in the ICU unit, but we can't exactly tell what exactly is requiring this patient to be on pressors. We can't tell what kind of shock this is. So one of the easier ways to kind of elucidate that before we get an official, further reading of echoes and other laboratory tests, we can go to the bedside and we can place a probe on our patient and kind of see what we're doing to our patient actively in real time. So if we do that and then we see that our patient has a low VTI, we can assume that there's one of maybe 3 types of shock going on: hypovolemic, cardiogenic, and obstructive. And so you see low VTI in a hypovolemic shock because you have low preload, right? So you have a low amount of volume inside the heart to begin with. So a low amount of volume is going to be pumped out of the heart regardless of its contractility function. So that's one reason that you can have a low VTI. Kind of going into the next reason you can have low VTI is because you have low function of the heart. If your heart's not pumping properly and it can't actually move the blood out of the heart, then you're not going to have that amount of blood or that measure of VTI change or increase, regardless of the amount of fluid that you give the patient, because it's not going to be pumping out. Whereas if you have a setting of obstructive shock where you have fluid inside the heart, you have a VTI that's measurable, it is low, but it's not exactly moving out of the heart. It comes out as a low VTI because there's just too much pressure outside of the heart in order for it to pump the fluid out of the heart, if that makes sense. In this case, you would also tend to see on your POCUS, you'll see increase in your RV size because there's, again, this increased backup of fluid through the lungs because it's not coming out of the LV, then it's going into the pulmonary circulatory, and then it's increasing that pressure on the right side of the heart. So you would see RV dilation. You could also see pericardial effusion to help elucidate kind of what the cause of your obstructive shock is. On the contrary, you can also see normal or elevated VTI in the setting of shock. That's usually in a setting of a distributive shock. We'll talk about a little bit more about the different types of distributive shocks and how we'll see the VTI change in those types of shock. But essentially, in this case, you have a normal amount of fluid inside the heart and you have a normal pump function. As a matter of fact, your heart is actually trying to increase its pump function. It's becoming hyperdynamic in order to increase the amount of VTI, increase the amount of blood flow being ejected from the heart in order to compensate for the low pressure in the vasculature in the distributive shock setting. So like I kind of mentioned at the beginning of this, was the the point of the VTI is to help us elucidate, one, what's exactly going on, but also how what we're doing is affecting the patient, and if what we're doing to the patient is improving or not helping the patient. So VTI is really the most helpful when you take it in sequential measurements after you've performed some sort of intervention. Like Dalan mentioned earlier, you can do some bedside maneuvers to help measure the assessment of fluid responsiveness in your patient. You could also give fluid pressor or fluid boluses. You could also try doing vasopressors or inotropes. All of these things, you want to get a measurement of your VTI beforehand to see what it is, and then you want to get a measurement a little bit after you've done these interventions to see if you've done anything to help kind of elucidate your reasoning for the shock that you have present or help rule out different types of shock. So some situations to consider would be things where you have a hyperdynamic ejection fraction, but that doesn't necessarily mean that you have good cardiac output. So what do I mean by that? So when you have hyperdynamic ejection fraction, or you have over a pump function that's working too hard, your heart's working really, really hard, it's pumping as much as it can, but you still have a low VTI. It could be, like I said before, because you have an empty tank, meaning you're in a hypovolemic state. But it's not always because you're in a hypovolemic state. You could have a low VTI, but with a normal or high preload if you're in the setting of severe left LV dysfunction, meaning your main pump function is completely out of whack. It's not working anymore, in which case you're not going to get a high VTI, right? Because you're not moving that amount of blood outside of the heart. In obstructive shock, like I mentioned before, similar situation, except this time your pump function works, it's just not working strong enough to overcome the outside forces on the heart, like in tamponade, where you have clamping down from the pericardial effusion on your ventricles, pulmonary embolism, or tension pneumothorax. All of these things, you'll have a normal preload, but you'll still have what seems like an impaired preload based off a low VTI, when it's really just the fact that your heart can't overcome the pressure to expel that amount of fluid out of the heart. Another reason you could see low VTI but a normal or high preload is if you have severe pulmonary hypertension. If your right ventricle is so weak because it can't overcome, it's been beaten down by the amount of pressure coming from the pulmonary arteries, then in that case, your RV can't push blood into the pulmonary circulatory system, in which case it doesn't go into the LV, in which case you do have technically a low preload or a low volume inside your LV causing your low VTI, but it's not necessarily a case of hypovolemic shock, right? Because you have normal fluid, a normal amount of fluid in your vasculature, your right heart just can't overcome the tension in the pulmonary arteries to pump it to the circulatory system, to the rest of the heart and the rest of the system. On the converse, you can also have a hyperdynamic ejection fraction while also having a normal or high VTI. And like I mentioned before on the previous slide, this is usually in the case of high output states, meaning your heart is trying to overcome the hypotension it's experiencing by increasing its cardiac output. So these are usually seen in the context of sepsis, thyrotoxicosis when you're in a huge thyroid storm, or anemia when you have very low volume to begin with. So you're trying to overcome these kind of low volume or low pressure states by increasing your cardiac output. That doesn't always mean that you have a high output state, meaning that doesn't always mean that your heart is actually working harder. Sometimes, like Dalan alluded in the last slide, you have severe aortic regurgitation where the amount of blood that is being ejected from the heart is kind of returning into the heart from that aortic regurgitation, in which case it seems like you're moving blood out, but you're really not, because it's kind of all coming back in. So while you're measuring this high VTI, it's all flowing right back into the heart because of the aortic regurgitation or the lack of the valvular closure to allow that blood to come back in. So you're moving less blood out of your LVOT in the overall state. So you're not having an effective amount of preload exiting your heart from that venous return, if that makes sense. Similar but not quite situation in thyrotoxicosis, sepsis, and anemia, where you just have these low low pressure systems in the vasculature, so your heart has to overcome that. And unfortunately, in anemia, for example, that's just a matter of, it is similar to hypovolemia in the case of needing to kind of replenish the tank, so to speak. So then moving on to how we can consider this moving forward is that our VTI, this is kind of a study that was done from a center that showed how VTI can be used as a diagnostic or prognostic feature, so to speak, in septic shock. So this was done to see if a low VTI or a high VTI or any measure of VTI had an impact on on a patient's 30-day mortality in the setting of septic shock. And this study did show that people who have low VTI indexes in the setting of septic shock do have an increase in 30-day mortality, meaning if your patient has low amount of blood being pumped out of the heart while in a septic state, then they have an increase in their 30-day mortality. So ideally, you would do things to help mitigate those facts. So that's just kind of helping to guide conversations with patients and patients' families to understand the clinical context that you're in the moment and what that could mean for the patient in the future, in the short-term future, and in the long-term future. So then lastly, just to kind of go back over everything in summary, VTI is a really easy way that you can use at bedside to assess your stroke volume. You just grab an ultrasound probe, place it on your patient, knowing that you have to get pretty accurate measurements, and that does get impacted by the way your patient is lying, the way the patient is behaving, the way the cardiac views are seen on POCUS, depending on the windows you can obtain at bedside. So that's some caveats that you had to remember when obtaining your VTI. You can also use the VTI mainly to help assess what you're doing is how it's affecting your patient, meaning is your patient being fluid responsive? Do they need more? Do they need less? What kind of shock are we sitting in? Do we need to reshift our focus more on cardiogenic shock now that we see that this patient has a low VTI? Things like that. It kind of helps guide our clinical judgment and making decisions moving forward. And again, mainly used and mainly beneficial in the setting of serial VTI measurements. So you take a VTI measurement, perform some kind of intervention on the patient, whether it be the fluid resuscitation or the pressor changing, to determine if what you're doing can get you an answer to what the patient needs or what you haven't answered yet. And then it also is important to remember that when you're obtaining this information, you have to consider the clinical context of the patient and how other parts of the patient's clinical picture can impact your VTI measurements and also how you should interpret your VTI. So really, at the end of the day, your VTI is very useful in very sick patients, like we mentioned before, in guiding clinical decision making, but it's also very user dependent. So you have to collect this data very consistently, meaning go through your ultrasound in a very methodical way so you're obtaining reliable information, and obtain serial VTI numbers so you're obtaining at least reliable information in the context of your patient, not necessarily in grand studies, because that would require more in-depth level of data collection. But that is our presentation on VTI and how to best use it in the context of clinical patients and how to best guide your clinical decision making. These are all the references that we used. And as said before, we are residents from the University of South Florida. Thank you so much for joining our talk today.